All right. Thank you for the introduction, and thank you, SAGES, for this opportunity to present. These are our relevant disclosures for 7 seconds. All right. So the utilization of the robotic platform during bariatric surgery has been on the rise since 2015. Currently, it encompasses up to a third of the total surgeries performed in the US. For general surgery trainees, it has become an integral part of our education as well. There are several assessment tools that can be used to evaluate trainee surgical performance during these cases. Programs such as Simple that evaluates surgical autonomy, or survey tools such as GEARS that looks at a global assessment during of robotic skills. However, these tools are limited and that is completed retrospectively and is subject to multiple rater biases. As such, there is a critical need for objective performance metrics that can overcome these limitations and allow for more robust feedback for the learners. So with the robotic procedures, objective metrics that can be extracted for such use. So objective performance indicators, or OPIs, they are measurable data such as system events, console activity, or kinematic movement of the instruments. So these are quantitative and objective with the possibility for providing immediate feedback. Previous studies have shown that OPIs are associated with surgeon experience in various fields, such as urology, thoracic surgery, and during cholecystectomy. However, these OPIs were found to be distinctively different between levels of experience during certain part of the cases. And specific OPIs that have been well studied in the literature are known to be associated with expertise. Instrument-related metrics such as bimanual dexterity, which is the ratio of the dominant to non-dominant instrument path length, are shown to increase with experts compared to novices. Similar metrics such as instrument path length speed, as well as a smaller workspace volume, have shown to be related to expertise as well. Time-related metrics, such as the percentage of total active console times, have shown to increase during residence as they increase in experience. So such utilizations of OPIs have yet to be explored during bariatric surgery. So the objective of our study is to assess whether these step-specific OPIs can effectively distinguish between experienced surgeons and trainees during robotic Roux-en-Y gastric bypass. So at our large bariatric center, we using the intuitive robotic system and its data recorder, we are able to capture robotic Roux-en-Y cases between 2021 and 2022, where both kinematic and event data were obtained. So we have the dual console system that capture both trainee and attending kinematics. The OPIs used for the study included the active times for both consoles of both hands, the path length the instruments traveled. From there, we are able to extrapolate the instrument speed, as well as the total percentage of active console time, and bimanual dexterity, and subsequently the total workspace volume normalized with respect to time. So a total of 31 cases were included for our final analysis. From that, 1,223 specific surgical tasks were extracted, which included the kinematic data of 2 expert surgeons with an average robotic volume of 900, as well as trainees with leveling experience from PGY2 to early fellows. All participants were reported to be right-handed. So we were then taking those 1,223 specific tasks and organized and grouped them into 8 critical steps for Roux-en-Y gastric bypass based off of the similar skills and actions it's related to each other. Some tasks such as a leak test and concurrent hiatal hernia were excluded based off of the smaller cohort. I'm going to focus on 3 of the 8 steps that had distinctively differences. The first being dissection, which is composed of steps for dissection of the gastrohepatic ligament, gastrophrenic ligament, and as well as posterior gastric dissection. During these tasks, we found that the attending surgeons had a higher bimanual dexterity of 1.3 versus 0.7, suggesting a better bimanual coordination and more balanced use. And then we found that the attending surgeons also had a faster non-dominant instrument speed of 3.6 centimeters per second versus 3.1. That's likely attributed to more efficient and proficient use of their instrument. During the gastric pouch creation, the attending surgeons displayed a similar high bimanual dexterity. However, their non-dominant hand speed were actually slower. We think that's likely due to the action-specific steps of this procedure, action that required a more precise precision of the instruments. Trainees had overall less active time of their dominant hand, suggesting a less active involvement and having more of a passive role. And lastly, during hand-sewn anastomosis, which is the creation of the gastrojejunostomy, trainees' overall active time and instrument usage were significantly decreased. Despite having a less active time, we found that the trainees had utilized more space and were generally a little bit faster with their instrument use, which could suggest it was a less refined movement compared to attendings. So these OPIs are capable of objectively distinguishing trainees versus attendings during these key critical steps, but it can also act as a tool to assess autonomy as well. During our recorded cases, we have found that trainees overall had a less active console time, with the exception of the defect closure step. And during this step, the trainees exhibit a majority of the active console time, and the OPIs were comparable. This indicates that the attending surgeons provided more time for the trainees to perform this task and is a suitable task for the trainees to perform more independently. So in conclusion, OPIs can objectively distinguish performances between attending and trainees, and these OPI differences are vary based off of step-specific tasks. So it is, however, it is essential to consider that these OPIs based off of the different task complexity and actions required to complete these tasks, as certain metrics may be different in assessing surgical proficiency and performance based off of the specific action it requires. So by comparing trainee OPIs, we hope that with the attending surgeons, we hope these indicators can serve as a valuable tool for assessing trainee readiness. Oh, why are these? So our limitations are mostly due to the low number of cases that we were able to record during this time. So we hope in the future we want to expand our recordings to include additional experienced surgeons to validate our data. Additionally, we hope to correlate surgeon-specific OPIs with patient outcomes to establish clinical relevance of these indicators. And ultimately, our goal is to use OPIs to develop an objective assessment tool that not only help facilitate robotic learning and feedback, but also aid in refining surgeon proficiency overall as well. So thank you, and I'd be happy to take any questions.